I don't know if.
Hello, everyone. Shall we get started? We're already, oh my gosh, 2 whole minutes behind. Yes, late. Just wanted to welcome you all to this month's meeting of the Children's Behavioral Health Policy and Planning Committee. And to say that I know we have a little bit of a change in our schedule. Unfortunately, we had an illness, and so we will be hearing from DSS today, but we will not be able to hear from Carolyn or Anthem because they'll be presenting together next month. I know that you're all going to be really sad about this, but it means we're going to end early. And given the season, I'm sure that is really depressing to everyone. So thank you all for being here. As always, thank you for your commitment to this work, and I will pass it over to my co-chair.
Just really briefly, and I want to just recognize everyone and thank you for today's meeting. This is really a reflection of what the committee had told us early on about having the policy conversation in conjunction with the financing and how that's so important from a sustainability point of view. So really excited that at least today we tell a large piece of that story through the Medicaid presentation from our wonderful experts at DSS, and then looking forward to that follow-up conversation about the role for commercial insurance, and looking forward to Carolyn's presentation when we get to that in January. So thank you.
Good afternoon, Erica Nowakowski, Executive Director with the Tau Youth Justice Institute, and want to welcome everybody today for our TCB meeting. Just a couple housekeeping, please, on your packet and or in on the screen is the QR code for the TCB members to please log in your attendance for today. And if there's any difficulty in logging in, please let us know or message myself or my staff on any of the login. Secondly, just again, some housekeeping. I think we have, as the chairs mentioned, we have a very good presentation by DSS. And what we would like to do is to have them present and then reserve your questions till the end. We will have plenty of time to go through the questions if you want to note them down. If you are attending virtually as well, you can enter those questions into the chat, and we will, my staff and I will monitor those, the screen. Again, just some housekeeping in regards to the, if you're here and you have your Zoom on as well, make sure that everything is on mute. Hand raising, questions at the end. This meeting is being recorded. And we just have one last housekeeping, and that's acceptance of the minutes for the November meeting.
So moved.
All in favor? Okay. Thank you.
Thank you. So myself and Ash will just give you the committee a quick update, as we'd like to do every month, on the TCB status of the operationalization of the work plan. We, as you may recall in previous meetings, we informed you all that we will be conducting listening sessions across the state. And we were planning on getting those kick-started this month in December. But I think we maybe were a little aggressive. So we were going to delay that a little bit and begin the listening sessions in January. And when I give the floor to Ash, she'll give a little bit more details around that. Ash?
Right. So with respect to the statewide listing sessions, let me just... Okay. With respect to the statewide listing session, we would like to partner with more agencies, so that we have active participations from those agencies when we conduct these listening sessions. We want more youth and families to participate in these listening sessions. And we want to also have a participatory approach with them, wherein we are just not taking feedback with them, but we would like them to provide more insight on what are the experiences that they have when it comes to children's behavioral health. So if any of the organization that you represent and you would like to partner with us, to enter into a small subcontract for that, we would welcome that. Or if you know of any agency who would be a good fit for us, please let us know. We would like to schedule planning calls with them and get this started.
One of the, just to elaborate a little bit more in regards to the subcontract, those subcontracts are specific to stipends for youth and families to reduce barriers of transportation, daycare, and so forth. And so, though, you know, we would partner with you all to help in the recruitment of youth and parents to be part of this process. This next slide shows you, which you have seen before, it's just an adjustment of the roadmap of these statewide listening sessions and what we, the specific steps that we are taking between now and into April, when you will receive a report that is hopefully comprehensive to help provide some direction as well to the strategic plan of this TCB committee. We will be releasing dates for each of these months, January, February, March, for the listening sessions, locations, and any registration information. So, you know, keep an eye out for our emails, but we really do hope to engage the community in these listening sessions. And the more we can get youth and parents at the table, I think the more of a robust, comprehensive report we will have. If you have any questions, please do not hesitate to contact myself or the staff. And now we would like to give the floor to DSS. Thank you.
Good afternoon, co-chairs, council members, and audience. My name is Fatma Toguni, and I am a Director of Medical Administration at the Department of Social Services. And part of my role is to oversee the administration of our behavioral health benefits. My predecessor here, Bill Halsey, will be here with me to answer questions. However, I will do most of the talking. I'll do the entire presentation. Thank you. Okay, so I'll give a high-level overview of Medicaid coverage for children's behavioral health services today. And I know that it's been mentioned that Carolyn will not be presenting, but I also want to say that Carolyn will be reflected a lot in my presentation today, because most of the data that I will be reporting was analyzed by them, and they help with the administration of our behavioral health services benefit. So just a high-level overview, I will go over and emphasize the partnership. I will talk about Medicaid's role in terms of coverage for behavioral health services for our entire Medicaid population. I would talk about the benefits that we cover, some initiatives that we're doing to improve access and improve quality of care, and I would also highlight some next steps. So now with the Behavioral Health Partnership, it is a partnership because we cannot impact children's behavioral health services without our sister agency, the Department of Children and the DCF, the Department of Children and Families specifically. The partnership was formed in 2005, 2006, and at that time it was the Department of Children and Family, the Department of Social Services, and the legislatively mandated Oversight Council. In 2008, the partnership expanded to include, at that time, what was called charter beneficiaries as single adults. In 2010, we expanded Medicaid, and in 2011, the Department of Mental Health and Addictions joined the partnership because they are responsible for the adult population. I will focus on children today because that's why we're here, but just so you're aware that the partnership oversees all the services for children and adults covered under Medicaid. In 2006, we contracted with then Value Options, evolved into Beacon and now Carolyn, and they manage the services for us. We do require authorization for higher levels of care to include inpatient psychiatric services, substance use disorders, psychiatric residential treatment facilities, and a lot more. Again, you can ask questions about those at some point, but I'm not going to go through all of them. So Medicaid's role, we are the largest payer for behavioral health services, especially children's behavioral health services. With the assistance of Carelon, our behavioral health, a partnership contractor, they help with managing our provider network. We have our own Connecticut Medical Assistance Program provider network. We have a list of covered services, and we also set our payment rate, and those are determined based on level of care by our rate setting, people with actuarial contractors, rates for inpatient levels of care based on tiers, and there is a whole complicated mechanism that I'm not qualified to explain. Our outpatient rates are based on percentages of Medicare, and we do have some provider-specific rates. I will highlight some population profile. Okay, population profile for our Husky youths, but I will provide a context for the Connecticut population. Most current census, we are 3.6 million people in Connecticut, and 20.2% of those people are under the age of 18, 51% female, and 78.4% identify as white, 18.2% identify as having Hispanic ethnicity. In quarter two of 2020, the Husky population, quarter two of 2020, if I can use that. Okay, sorry, the clicker. In quarter two of 2023, the Husky population was over 1 million people, and 30% of the state's population, 30% of the 3.6 million. The youths in the Husky population within the ages, within the, no, it's not working. Okay, I'm sorry, the clicker is not working. Okay, all right. So stay there for now, please. Thank you. So the youth in the Husky population for ages 0 to 17 years represent 34.3% of our entire Husky health population. That's not the real slide, but we'll stay there. There's been an increase every quarter from the first quarter of 2021 to quarter two of 2023, with the highest being at 739,283 members in the second quarter of 2023. The youths are 51% male and 49% female. So this slide is the racial breakdown. What's notable in this slide is that we have a high category that's identifying as unknown. And there's been an increase in that category from 51.2% in quarter four of 2022 to 52.8% in quarter two of 2023. The reason being, the federal regulation limits the type and amount of data that we can collect for Medicaid eligibility. So race is not a required element, a data element when people are applying for Medicaid. And there are implications for that, as you can tell. Next slide, please. So this slide depicts the youth race within Hispanic ethnicity. Consistent with the previous slide, there's a large number or percentage of youths who are identifying as unknown, or maybe they're not reaching them to get their race because this is all through our Medicaid eligibility files. Youths who are identifying as white are the largest known racial group at 25.8%, and 23.9% of them are identifying as having Hispanic ethnicity. Youth who identifies as Black, 18.6% of them in quarter two of 2022, decreased to 17.8% in quarter two of 2023, and 16.7% identifies as having Hispanic ethnicity. Asian youths, 2.8% of them in Q2 of 2023 identify, 5.9% of them identify as having Hispanic ethnicity. And there's a small category at the bottom there that refers to another race. They're less than 1% of our Husky youths, and 33.2% of them identify as having Hispanic ethnicity in Q2 of 2023. Next slide, please. So this is a similar slide. Thank you. This is a similar slide to the previous one. Again, in Q2 of 2023, 77.4% of youth identified as non-Hispanic ethnicity. 22.6 identified as Hispanic ethnicity. The total volume of non-Hispanic youths increased by 11.5% over the 10 quarters, from Q1 of 2021, I believe, to Q2 of 2023. And then the total volume of Hispanic youths decreased by 2%, again, similarly over the 10 quarters. And the youths who are identifying as unknown, 24.7% of them identify as having Hispanic ethnicity. And then the largest known racial group who identify as white, I believe I mentioned 25.8% of them, 23.9% identify as having Hispanic ethnicity. Next slide, please. So now I'll go a little bit into the services we cover under Medicaid for children's behavioral health. Thank you. So this slide contains a lot. We cover services across the continuum of care. I am not going to go into all of them, but we do I'll highlight the home-based services we cover: multidimensional family therapy, family functional therapy, multisystemic therapy, and the in-home intensive child and adolescent services. We cover emergency services, observation, case management, and psychological testing. These slides are by no means exhaustive of what we cover. This slide, I will expound a little bit on what we mean by the school-based health centers. Those are centers that are enrolled as clinics, and they have access or can access all of the services on our medical clinic fee schedules: preventive visits, site evaluations, mental health services, group and individual counseling. Children are able to access at these clinics. FQHCs can also enroll as school-based health centers, and when they offer behavioral health services, they can also bill Medicaid and get reimbursed for those. Then we have the school-based child health. So those are under the Department of Education. So children enrolled in schools, if they qualify under the Individuals with Disabilities and Education Act, and they meet the requirements for special education, they're Medicaid eligible, and there's parental consent for services through an individualized education plan or 504 plan. These students are able to get services in school, and the schools can bill us for a psychiatric diagnostic evaluation, psych testing, individual psychotherapy, group and family therapy, and mental health assessments. And we also cover substance use disorders through our substance use disorder 1115 waiver, demonstration waiver. We cover e-consults that we're going to implement sometime in the first quarter of 2024, where we will establish codes where primary care providers will be able to access specialists, and both will get paid, just to expand access of services to this population. Next slide, please. I'll highlight some Medicaid initiatives to continue to improve access and quality of services for our Husky youths. There is a lot on that slide, but I will highlight a couple of them. The first two, the pediatric inpatient psychiatric bed add-on and the pediatric inpatient psychiatric acuity rate add-on, were born out of our experience with COVID. We wanted to improve access that's what the bed add-on is for. And we also wanted to basically reimburse providers for the level of acuity with which children were presenting in their facilities, and that is that still exists. I also want to highlight our pediatric inpatient psychiatric with medical acuity rate add-on that will be implementing sometime first quarter of 2024, and that state plan amendment is currently under development. This pertains specifically to Connecticut Children's Medical Center because they'll be adding 12 beds, and these would be psychiatric inpatient beds that would care for children who present with psychiatric illnesses with a medical complexity. And so we're still working at that. I did mention the e-consults and integrated care for kids was implemented in July of this year. It is a model where youths under 21 years old receive wraparound services, targeted case management in certain locales in the New Haven area. Next slide, please. So some initiatives we are considering, we do have the Urgent Crisis Center. I'll talk about that later. It has its own special slide. I know you all were interested in hearing how we're doing with that. I have to mention the rate study that is underway. DSS is conducting a rate study that includes behavioral health services and dental services as part of the first phase of the study. We have contracted with Myers and Stoffer, an actuarial firm, and we intend to present an interim report to the legislature February 1st of 2024. Next slide, please. So with the children's urgent care centers, some urgent care centers are up and running already through ARPA funds under the Department of Children and Families. However, we are currently working to ensure that after, I believe, April of 2024, that those services can be sustained for children who will be visiting those urgent care centers and a Medicaid that we pay for those services. So what we have done is that these urgent care centers will have access to our outpatient behavioral health services fee schedule. So they'll have access to all of the codes on that schedule. And then in addition to that, we're adding specific codes. We're adding a triage assessment code where the nurse or whomever is at the reception desk will be able to determine whether the kid is in fact at the appropriate level of care. We are adding a nursing assessment code where for the first 60 minutes, and then another code for the subsequent 15 minutes after that for assessments. We are adding a crisis code, which will be billed again for the first 60 minutes, and another code for an additional 30 minutes post-assessments, because we're anticipating that children who will be presenting at these centers would require frequent assessments to ensure that, in fact, they can go to whichever level of care, whether it's the community or whether it's a higher level of care. I also want to point out that most of the services would be billed under the crisis codes. So at this point, we are developing the SPAs, we're working the system to allow this to be implemented by April 1st of 2024. Next slide, please. I'm going to give some high-level data about utilization of services in Medicaid. So this slide depicts authorization based on in-state pediatric discharge volume and the average length of stay. In the first quarter of 2023, there were 685 in-state inpatient psychiatric discharges, which was slightly higher than what was authorized at 665. And the discrepancy is possibly due to the fact that our Children's Medical Center does not have an inpatient psychiatric unit. So Carolyn that does our authorizations cannot authorize for that level of care at the CCMC. So therefore, the children will still get admitted as a medical stay with a psych component, but that's still counted as a psych admission. So that's why there may be a slight discrepancy. Next slide, please. This slide depicts the youth inpatient facility acuity-based rate add-on I did mention that as one of the initiatives we implemented in 2021 to encourage, access to care and improve quality of care. There were 204 episodes from Q3 2021 to Q2 of 2023. 148 unique youths used that service, and 38 of the authorizations for this particular add-on occurred in Q2 of 23, and it was the most used during that quarter than any of the quarters since it was implemented in 2021. Next slide, please. This slide is claims-based, and it depicts the claims-based inpatient discharge volume and the average length of stay. The trends, hold on. All right. So the trends in the discharge volume and average length of stay are similar to the authorization-based data. The discharge volume increases for three consecutive quarters, from 448 discharges in Q3 of 2022 to 685 in Q3 of 2023. An increase of 237 discharges at 52.9%. The average length of stay, no, please, thank you. The average length of stay increased from 15.8 days in Q3 of 2022 to 16 days in Q4 of 2022, the highest of any quarter. I also want to mention that Q1 and Q2 of 2023, the average length of stay was 12.4 and 12.7 respectively. Next slide, please. Okay. This slide depicts authorization-based youth inpatient facility per provider 7-day readmission rate. In the first quarter of 2023, the 7-day readmission rate for all youths in network per providers was 2.9%, 41. And of the discharges that readmitted, most returned to the same provider. That's a 68.3%, a total number of 28. And the 7-day readmission rates by in-network per providers, the range was 0.7, meaning one readmission out of every 137 eligible discharges, to 5.2%, meaning 10 readmissions out of 191 eligible discharges. Next slide, please. Okay, another inpatient utilization data. This slide depicts authorization-based youth inpatient facility per provider for the 30-day readmission rate. We just did a 7-day, now this is the 30-day readmission. So for the first 2 quarters of 2023, the 30-day readmission for youth for in-network per provider was 11.9%. And of the 166 discharges that readmitted within 30 days, 51.8%, 86 of them returned to the same provider. And the range was 6%, meaning 8 readmissions out of 133 eligible discharges, to 17.8%, 34 readmissions out of 191 eligible discharges. Next slide, please. Okay, so this slide depicts authorization-based youth inpatient discharge delay volume. So there were 38 delayed discharges in the first quarter of 2023 before it dropped to 22 in Q2 of 2023. The average wait time for youths for appropriate services increased from 25.7 days in the first quarter of 2023 to 45 days in Q2 of 2023. there could have been some systems level factors that may have contributed to this trend. And some of them included a temporary decrease in bed capacity at the lower residential levels of care. Certain providers had to pause admissions because of workforce capacity issues. These programs have since, they have gotten back online, and state and community psychiatric residential facilities have added beds during the first half of 2023. And Carelon, our contractor for the partnership, continues to work closely with hospital and community providers to ensure that members continue to get appropriate clinical services whenever they're ready to do so. Next slide, please. This slide depicts utilization based on diagnosis. In the first quarter of 2023, all in-state discharges for primary diagnosis of depressive disorders at the highest was 79.3%, followed by post-traumatic stress disorder at 3.7%, disruptive impulse conduct disorder at 3.1%, followed by schizophrenia and other psychotic disorders at 2.9%. And this is consistent with previous years. Next slide, please. This slide depicts authorization for autism services, authorization for autism services. So the authorization volume for all services increased by 4.6% in the first quarter of 2023. And there was an additional 8.5% increase in quarter 2 of 2023. The authorization volume reached a 10-quarter high at 2,331. The treatment plan development, program book development, and behavioral health assessments declined in the first quarter of 2023. However, both of those picked up again in quarter 2 of 2023 and constitute the bulk of the authorized services. There was also a 29% increase for diagnostic evaluations in quarter 1 of 2023 with a 10 quarters high of 481 authorizations. There was a slight decrease to 468 authorizations in quarter 2 of 2023, and the decrease was from the 481 auths previously. Next slide, please. This slide depicts lower level of care utilization. So we're talking about the intensive outpatients, the intensive in-home child and adolescent psychiatry level of care. The intensive outpatient mental health is the most utilized level of care at 39% in quarter 2 of 23. The ICAPS was 27.6%, partial hospital program 13.4%. And the ICAPS is the most utilized by members ages 3 to 12 at 54.3%, and mostly males, 53.6%. The youths who identify as unknown or who are unknown, 42.1% of them utilized the ICAPS in quarter 2 of 2023. Now I believe we'll go to some expenditures. Thank you. So I'll give high-level expenditures. That's a line graph. It's difficult to read, I know, and I'm sorry, and I couldn't, by the time I thought about getting the actual figures on there, it was sort of late, but I can give you some of the numbers. So that slide depicts the expenditures for all youth services 0 to 17 years. And again, the same 10 quarters. So except for quarter 3 of 2021 and quarter 3 of 2022, the expenditure sits between 85+ million to slightly under 95+ million for all services. There's been a steady upward trend since quarter 3 of 2022. And I did a quick calculation for the 4 quarters, just the first 4 quarters of 2021, for all youth services. The approximate expenditure was 337 million just for the first 4 quarters. 2021, I did not do the whole thing. Next slide, please. This slide depicts the expenditures for birth to 3. As you can see there, there's been a steady increase in expenditures from Q1 21 to Q2 23, 5.4 million to slightly above 7.7 million in Q2 of 2023. Next slide, please. This slide depicts the expenditures for psych residential treatment facilities for community and state. The community residential treatment facility expenditures ranged from under 1.3 million to approximately 2.9 million. That was in Q2 of 2023. And the state PRTF expenditures fluctuated but stayed above 9.3 million, with a peak of 11.3 million in Q4 of 2021. Next slide, please. So this slide depicts expenditures for youth outpatient services, this youth ages 3 to 17. Again, some fluctuators noted in the expenditures, with the lowest expenditures in Q3 of 2021 at 17.6 million, and Q3 of 2022 approximately $18.5 million. Q1 of 2023 had the highest expenditure at $26.1 million, down to $23.2 million in Q2 of 2023. Next slide, please. This slide depicts expenditures for all the autism spectrum disorder services. It just shows a steady increase in expenditures from approximately 8.1 million in Q1 of 2021. Now we're at 14 million in Q2 of 2023. Next slide, please. This slide depicts expenditures for the youth ICAPs. It shows a downward trend in expenditures from Q1 of 2021, which starts at approximately 4.9 million to the lowest expenditure at approximately 3.6 million in Q4 of 2022. There's a slight increase again to 4.3 million in Q1 of 2023, with a dip to 4.1 million in Q2 of 2023. Next slide, please. Okay. This slide depicts expenditures for youth, inpatient facility, community, and state, ages 3 to 17 years. The trends are similar for both groups, hovering between 7.1 and $8.5 million for the first 3 quarters of 2021. And the IPF state peaked to approximately $10.1 million in Q4 of 2021 before leveling off in Q2 of 2022. The lowest expenditures in Q3 and Q4 of 2022 ranged between 4.3 million for the IPF community and 4.1 million for the IPF state. Overall, the total state IPF expenditures are slightly higher than the community IPF. Next slide, please. So now the next steps. That's my favorite slide. Now the next steps. So I did mention on a high level that we are on target to develop an interim report that will be presented to the legislature come February 1st on 2024 for the rate study. So that I will leave there. In the meantime, we plan to continue to collaborate with our key partners, the Department of Children and Families, the Department of Mental Health and Addiction Services, and there are other key state agencies that are involved, community providers, the families, the members themselves will continue to collaborate and work with them to improve access as well as quality. We'll continue to work with our contractor, Carelon, to continue to assess the systems for any care gaps and continue to implement programs to improve access, care quality, work on our data collection, especially from the DSS side. We do have a data governance committee that's exploring ways where we can begin to collect the needed data, such as race and ethnicity, sexual orientation, gender identity, language, to collect as much data as we need to be able to address gaps, address disparities, health disparities, and otherwise, and improve outcomes for all of our members. We are also exploring alternate payment models, which I believe Laurie was supposed to be talking about today about what's going on in other states. But we are looking at alternate payment models for our inpatient level of care as well as our outpatient level of care, to be able to reimburse providers enough to be able to improve access to behavioral health services for children, improve health equity, improve care quality, as well as control some costs. Next slide, please. I believe this is just a reiteration of what I said before, but overall, it is a partnership, and I want to just reiterate that it is a partnership. DSS is not able and will never be able to move the behavioral health system for children or adults, but I know we're here focusing on children alone. We need all of the partners, you legislators in this room. We need our state partners, our community partners. We need our families. We need our members to work together to improve the system. And I appreciate you inviting DSS here today to tell you about what we cover and how we cover it, and we'll be open to questions. Thank you.
Thank you so much for all of that information. I know that we have several questions, so I'd like to start with Representative Walker.
Thank you. Thank you, Madam Chair, and thank you, DSS, for your presentation. I understood maybe 2 or 3 pages, but I thought it was, it was very informative. I want to first ask about, most importantly right now, the children's urgent care centers that we have in here. Going to that slide, it says that DSS is proposing to use the following billing codes for the urgent care centers. So are those codes that you are proposing, are those the ones that are being utilized now for them? I know they're being funded under ARPA, but are the guidelines that are set under here that DSS is proposing, are those categories the exact ones that we're hoping, what we're billing right now with the UCCs?
I am not sure what you're billing with right now with the UCCs, but the UCCs will have access to our existing behavioral health outpatient fee schedule, and we are adding codes that I have here that are not currently on the schedule. So we are adding those codes because they will be specific to the needs of the of that population. And I have CPT codes 96217, which will be a triage assessment code, T1001, which will be a nursing assessment for the first 60 minutes, T1002, subsequent 15 minutes nursing assessment, 90839, which is a crisis code, and it is used to bill for the first 60 minutes of care, and 90840, which is another crisis code, which will be used to bill for each subsequent or additional 30 minutes of assessment. These are not on yet. We are working with our systems people to now add these codes, and they will be specifically for the UCCs to bill for services in addition to all the other codes that are available on our behavioral health outpatient fee schedule.
Okay, so I guess,
One more?
Can I
yeah.
add one thing?
Yeah. Yes.
So Bill Halsey from DSS. So 3 out of the 4 urgent care centers right now are licensed outpatient clinics that have full access to our current fee schedule that's available to them today.
Okay.
So psychiatric evaluation, they should be billing that. All of those codes are available to them today. But as Fatmata said, they don't have access to the nurse triage, nurse assessment, and the crisis codes.
codes. Okay, but they will be phased in by April.
Yes.
Okay, but the expense that the UCCs are experiencing right now are under ARPA funding. But I guess, under ARPA funding, it's a big question mark. What exactly are they able to bill for under ARPA funding? Is it a generic
That would just be, that would be grant funding
grant? funding?
from Department of Children and Families. And whenever they see a Medicaid eligible child, then they can use all of the billing codes that are on the fee schedule today as a outpatient licensed facility.
And my final question on this would be, will we have a reconciliation just before 2024? I mean, before April 1st, 2024, to make sure that they've been held harmless in any of their expenses?
DSS and DCF are working very closely on trying to establish a fee schedule that takes into account as much cost as we can related to the services. But
So-
there'll be some, I think, some braided funding for a little while.
Okay. So I would just ask that you bring back to TCB what the reconciliation is, because the reason why I sort of wanted, it's one of the first things that we've been focusing on in our committee. And the other part is to make sure that we're not discouraging people to participate in this system. We're trying to make sure that we help the nonprofits and the providers are being held harmless, because we're creating this, and so we don't want anything to sort of fall through the cracks. Thank you, Madam Chair.
If I can just build, thank you, Representative Walker, because you took the question that I was going to ask. So it allows me to just build on what you had said, because I think this is an important distinction, one that we've grappled with at TCB and among advocates about the monies that were put in for ARPA were put in under DCF. And that was with the intention of scoping, scaling, designing, and initiating new services, right? So the initiation of those services by necessity required some upfront investment. And then the question I think you asked today, which we're partly answering through Medicaid, is moving forward, where in the budget do we see that money? It won't be necessarily as a block grant to DCF anymore. But I think what I'm hearing Fatmana and Bill reassure us on is a lot of that for everyone who's Medicaid eligible will roll into the rates that Medicaid has and be through the billing code of Medicaid. So that makes me feel really good about the fact that our experiment has worked. You know, we primed the pump to initiate a new service type, and now we're sustaining it through commercial payers like Medicaid. And it had our other colleagues been able to present, they could have talked about the commercial insurance space, which is important. And I know that just as a teaser for the group, Office of Health Strategies is doing a parity study on the rates between Medicaid and commercial for behavioral health. So I'd be interested to sort of see their findings when they come out too. So thank you.
Thank you. I just want to jump in there. I do think that, and I appreciate the work that DSS and DCF have done together to think about what does billing look like in the short term, what are the possibilities in the long term. I want to emphasize as an organization that operates one of the urgent crisis centers, that as designed and as implemented, although these reimbursement sources are critical to sustainability, it will be a braiding approach, I think, not even just in the short term, but potentially in the longer term. So the reimbursement alone, a fee-for-service model alone, will not sustain the program as designed.
Hello. I actually have two questions. When is the last time a Medicaid rate study was done? And if it was done, what was the result? What came out of it?
We are actually in the process of doing a Medicaid rate study. But we're going to get our first response back in February. It was broken up into quadrants, and I'm not going to be able to tell you what, I'm sorry. It was broken up into quadrants, so I'm not exactly sure which is in which quadrant off the top of my head, but we're working on it right now.
I meant before this study.
So many years
Historically.
ago, it was not worth even talking about. We
Okay.
haven't done it in probably 20 or 30 years, and so that's why we started it this year.
Wonderful. Second question is, you spoke a lot about inpatient intensive services but not a whole lot about outpatient services and recognizing that it's the most widely used and available service. I'm just wondering if there's anything you could speak to outpatient services that are lower levels, less intensive.
I provided the data that I could at that time, but what exactly are you looking for with regards to the outpatient services?
Well, you
It's-
had mentioned that some other codes were coming for more the more intensive services, and I'm just curious if there's been any thought into what's needed.
We are exploring different models. We are exploring ways to develop our outpatient services delivery, because I do agree with you that it is where care needs to be received, and it's actually the largest area where we provide behavioral health services. So we are currently working on it. We have not identified codes. We're trying to look for a model that we can implement for our outpatient behavioral health services delivery.
So we're going to go take, I know that there, Alice, I see you and we will come back to you, and Sarah, but I wanted to recognize Ms. Benenga, Tammy, on line and have her ask her question. Thank you.
Hi, this is Tammy Fenningham from the Department of Developmental Services. A lot of the new programs that have started are exclusive of those kids with intellectual disabilities and autism, because the expertise aren't at those locations. So even though this is said, oh, all kids can have access to it, it really is not true for kids with intellectual disabilities. The same is true for outpatient, for ICAPS, for IOL, where we'll get reports that say the kids meet that level of need. However, they don't have the expertise to use that program for these individuals. I just didn't know if there's anything currently going on to make sure all kids in Connecticut, including those with disabilities, are able to access these services.
Tammy, that's a tough question. So I think when Fatmata was talking about partners, we are certainly willing to work with you to think about how to better serve that population. So we're open to those suggestions. We want to make sure that children and youth with intellectual disabilities have equal access to those services. So we welcome your participation and feedback and recommendations in that area.
Thank you.
Thanks, Bill, and thanks, Tammy, for that question. Just if I can add on, one of the things that came out of the priority bill in the House 5001 this year was to really look at some of the eligibility criteria and whether services need to be updated to account for different things, such that there's not a bright line rule where IQ is the only determinant for eligibility for state programs. And I know a lot of different agencies in the executive branch were tasked with different aspects of that bill. OPM in particular has received some resources to go out for a consultant to help us do a design and look at level of need determination and eligibility criteria and what's used in other states. So I think that'll be incredibly informative to accessing programs like Medicaid and the services that we're talking about, like UCC. But good reminder, Tammy. Thank you for elevating that issue.
Alice Forrester.
Thank you. And Fatima, thank you so much for a great run through of some of the data. I would have loved to have seen the numbers, and I'm sure you would have too, when you looked at the data. And thank you, Representative Walker, for your honesty around understanding a lot of the data. I think it's eye twisting, if that's a right word. But I have two questions around ASD and autism services, just for clarification, and perhaps I'm incorrect. On the first slide on ASD services, there is the services that are listed, which are program book development, behavioral assessment, diagnostic, service delivery, and direct obs and direction are really very much focused on both diagnosis and BCBA treatment, correct? And that there is no special service rate for working with families or kids with autism. And I know that OPM is going to be doing some of that work, but that's really truly that restricted. It's not services in its general sense. It's just specific to the BCBA. Is that correct?
I want, you want to go? There is a service billing code
Yeah.
for direct service by a BCBA or a tech.
Right. But it's all within the development and program book of a BCBA, whereas,
No,
you know,
there's a direct service billing code.
right. But after, if you're not delivering BCBA services, if you're delivering mental health services, social skills services, and all of those go under the outpatient category.
Yes.
Right. And, you know, which we know is underfunded in some ways, but that's just my thing. The other question I have is the cost that seems to have gone up in the ASD. Is that include the waiver dollars? Okay.
No, it doesn't include the waiver dollars. It's just the state plan.
The BCBA, the diagnostic testing, and the BCBA.
Yes,
When you say BCBA, Alice, so it is under the direction of
Right.
a BCBA or a licensed practitioner, mostly delivered by a tech. So
Right.
I just want to be clear in language. So this is direct service provision.
Okay. I mean,
under state plan.
Yeah, it's just interesting that it's gone up so much because the story on the street is that a lot of the services are not being able to serve because there's a lack of BCBAs in the state. And so I'm just interested in that growth there. The other question I have, pardon me, I'm like cheating, asking multiple questions. The other question is just around the birth to 3, which is really interesting to me is even though we're not a birth to 3 provider, the system moved to a fee for service. Gosh, everything is like pre-COVID. Multiple years ago, if anyone's here from birth to 3, you can tell me when it went to fee for service. I guess I was really interested in how did that go in terms of, because, you know, it's sort of the theme that we're talking about, braided and blended funding. Birth to 3 stopped funding direct services and am I correct? And they moved to a fee for service model.
I think you may be misunderstanding, or maybe I reported it wrong. It is an age category. It is not the birth to service program per se.
Right, birth to 3, which is in-home services for children who've been diagnosed with developmental issues that need to be caught up to 3. Is that correct? That we're talking about?
No, it's just an age, just like I would say 3 to 17 years. It's not the program. It is just the age. So like I reported on 3 to 17 years, I was reporting on, you know, from 0 to 3 years.
Okay. It would just be interesting at some point to see how that transition from grant funding to fee for service moved in terms of numbers of kids served and expenditures in terms of, you know, did the costs go up? Did they go down? And maybe that's something Commissioner Bai can talk to us when we're using that. But I apologize because I thought it was birth to 3. And I think I just have, I think those are the questions. Thank you so much. Cheers.
Sarah Egan.
Hi, thank you for the presentation. Couple thoughts. One, in terms of structure moving forward. So most of the data provided is utilization data, utilization and expenditure data, right? And in the moving ahead notes, we talk about assessing throughput and service gaps. What is the structure, if you could talk about the structure and methodology for assessing I mean, I assume discharge delay, is one of the things to talk about throughput, but about service gaps when we don't seem to have ready access to waiting list data, right? How many people need versus the ability to access at intermediate and outpatient and home-based level of care. So how do we assess that just looking at the utilization data? And then I have a follow-up question.
Sarah, thanks for that question. My presenting of this data, there was really just to give a high level overview. I didn't take it all the way to the end. I just wanted people to have an idea of, what Medicaid covers and the utilization and the expenditures. But we do have a structure in place because I've emphasized partnership, and we have Carelon. Carelon, they are the BHP contractor. So in terms of monitoring the system, looking at systems throughput, looking at the discharge delays, gaps in services, providing technical assistance to providers, trying to ensure that members get services and at the appropriate levels of care. Carelon is the front-facing entity for the partnership. So I do see, if you all want Carelon to come at some point to do that presentation on the information that you're requesting, I think that will be more appropriate, because I cannot speak to that at this point because I'm not at the front and center of that.
Yeah, I appreciate that. And I think what I just would emphasize, and I'm sure we would all agree, is that in assessing the adequacy of our continuum of care and the pace at which families access care when they need it, we need a really robust data structure for that, right? And I think that even Carelon has pieces of that, but not all the pieces that we need, right? So for example, if I just went down that list of like home-based services, functional family, what can families access in their home, right? Functional family therapy, multidimensional family therapy, and ICAPS, we see that the expenditures are going down. We see the admissions are going down. That's probably workforce related. It's not need related, right? We know need is high, workforce is down, admissions are down, but we really have no sense of need, right? We have no sense of how long families wait for that level of care. And there are lots of reasons for that. So I'm just raising that as a structural issue, that as we move forward with the goal, right? The whole point of this is, we all have that goal, that's something I think we really need to look at. My follow-up question has to do with the rate study, Fatma and Bill, which is probably very complicated. And, it would be helpful, I think, at some point to have a summary of what the methodology is for that rate study, who is doing that, if that's being done through a vendor, what the scope and breadth of that is. Senator Austin referenced quadrants, but is part of the return product going to include recommendations not only for rate setting, but for a structure for state rate setting, and two, and what the criteria should be in that, what that should look like. And then two, any recommendations or opportunities for innovative rate structure that would allow for, different approaches to reimbursement, including case rate approaches and other opportunities for funding service delivery. So like this, what is the scope of what you expect in terms of recommendations around that?
Sarah, thanks again for that. That's another great question, and thanks for your insights. I have not seen the preliminary report at this point, but we are hoping that we would get not only the interim report, but also some recommendations, right, in terms of how to continue, whether it's monitoring rate or some type of a methodology. However, I am not the one leading that effort, neither is Bill Halsey, but we will, this report is due to the legislators February 1st of 2024, and I'm sure that at some point we all will be able to have access, I would hope. But that's really all I can say at this time.
Yeah, and thank you, Fatmana, for answering that, and thanks for the question. And so I could just add some commentary here. One, I think that we were really wise in working with our legislative partners to recognize that a study is only as good as its actionable information. So whereas we could have wanted a study that did an extensive look at recommendations, innovations, every state strategy, I thought one of the good things we came up with is a framework that allowed us to tranche out behavioral health, primary care physician specialists, and dental as being high need areas that needed attention soon, and then framed out what we want to see, which is benchmarking to our neighboring states, looking across for equity, and looking where access issues could be most impacted with rate differentials or a rate increase. And so I think on first instance, our laser focus is going into a short session. Let's take the feedback that we can act on, get some good intel for that small piece, and actually make it usable with the recognition that there's then a second follow-up study that I think, Sarah, to your point, goes broader. What's the innovation? What are the changes? And will be more of a tranched approach. So I think we did a decent job, and I appreciate a legislative partnership in making sure that we did that. We said, what can we act on and what information do we need to make a reasonable action in the short term? And then let's not lose sight of a systemic approach. So I think that's what you're going to see from Myers, that's been contracted with DSS and is very familiar with a lot of our rate studies. They've done waiver rate studies for us. So I think that they're well positioned to give us some recommendations going into the biennium.
So to add on, again, I had some of the same questions about where is the need highest and where are the biggest gaps in service. But that is why we originally wanted Caroline and Anthem to come and be part of this whole presentation. And it's unfortunate we can't see this in continuity with the data that we have plus the information that we would have gotten, but we'll have to get that next month so that we'll have a bigger picture. Yes, you had another question? Sorry, I'll get to you.
I did. I had a question actually about the PRTF expenditure slide. I was interested in the significant gap between the expenditures for the community and state PRTF. And I wondered to what extent that was a function of capacity. Are there just lots more state PRTF beds, or are there other factors that contribute to that gap?
I believe we have 2 state facilities and 3 community PRTFs. I believe it's based on the rate methodology. Without going into details, again, I'm not qualified to speak on rate methodologies. I do believe that's the fundamental difference there. Bill, do you want to add anything?
Again, this is a large rate discussion, but when we pay our state agency partners, whether it's Department of Children and Families for SOLNIT or Department of Mental Health and Addiction Services for Merritt Hall at CVH, we use a certified public expenditure payment process, which is different than a fee-for-service process that we use for the private providers. So the rate structure is quite different in how we pay state facilities versus private providers.
You have a virtual hand.
Michelle Scott.
Thank you. So it is very understandable and appropriate that race and ethnicity is not required for eligibility for coverage. However, when you were providing the data, there was a lot of youth that are not that were in the unknown, right? So we're up to almost 200,000 youth that we're not tracking. And so I would ask that we, or you, now we figure out some way to close that gap and to collect that data and use it, use existing data elsewhere to cross-reference or to be creative in collecting it so that we're making sure that we're capturing appropriate services when we are thinking about coverage and making sure that there's access. And then also for the group of individuals and families that speak other languages, making sure that the interpreter services are covered for behavioral health services for our youth, especially because some of these youth are being forced, many are being forced to interpret not only for themselves or for their families. So, you know, one, collecting data that accurately identifies as much as possible the 200,000 that we have as unknown, but then also making sure we have interpreter services that are appropriate.
Thank you very much. I appreciate that comment. I just want to let you know that we are aligned in that. That's a DSS, the partnership's priority. We've been having those conversations with Carolyn and all of our contractors, as a matter of fact, on how to improve data collection we can be able to address where the gaps are, address the disparities, and be able to impact them. We're also working with our data governance committee to see how we can improve it from our eligibility side, because that's where we get the data feed, and what we get is what we transmit onto our contractors. So we need to build it there, but I absolutely appreciate that comment, and we will take that back as well.
Commissioner Gifford, online.
Hi, thanks. Good afternoon, everyone. I just wanted to build on Claudio's remark about the study that the legislature authorized the Office of Health Strategy to do, because it very closely aligns with some of the questions that have been raised this afternoon. It's a bit of a complement to the rate study that Fatmata discussed, and it's very specific to behavioral health. So just to remind everybody that the phase 1 of the report is a environmental scan of workforce issues, which have been raised today. And then we're looking at two comparisons. One is the comparison between Medicaid Husky rates and commercial rates for behavioral health services. And the other is the parity between behavioral health and physical health rates, both in commercial and Husky plans. So that work is well down the path. We've been partnering with our sister agencies on that, and we'll be able to share those results with this group as they become available. But I wanted you all to know that there is work that's well underway. It's been commissioned. The contract has been procured and is underway to get that work done. So that'll be available to this group for your information as you proceed.
Thank you. And since we have a little bit of time left, we'll circle back to Alice Forrester.
I'm sorry. This is a question for Commissioner Gifford. I was just wondering if when you are looking at the Medicaid and commercial rates, is there going to be an opportunity to press the commercial providers to get closer to the rates that are currently contracted? I know everybody has different contracts and some are good and some are not so good, but and then are you considering it in particular for families who have a high deductible plan or self-insured, as you see that those numbers are, that the burden on the family is so extraordinary that they're unable to access services?
Thanks, Alice. So the point, I think, of this study and the reason why it was commissioned and authorized was to get answer to the question that you and others have raised frequently, which is that in some cases, and maybe in many cases, Medicaid is actually a better payer than commercial for some services. And so we'll have actual factual data about, I'm sorry, I didn't mean that that the anecdotes weren't factual, but we'll have a comprehensive view of that from our Connecticut All Payer Claims database that will illustrate by service where there's a difference between Husky and commercial rates and for which services. And so to your question about, will there be a mechanism for commercial plans to raise their rates? That is not within the state's control necessarily. That's something that's negotiated between providers and insurance companies. So I think that the goal of the study is to shine a light where there, may be some disparities, and then allow the market to maybe repair if there are some disparities that need to be addressed. And then with respect to the high deductible plans, that's not a feature of this particular study. We'll be looking at total allowed amounts that are in the all payer claims database, but we could talk some more about whether that's another set of analyses that we could look into, because of course, that's an important element of whether the service is actually affordable.
Okay, thank you all. If there are no other questions, there is one more question. Sarah?
Taking advantage of that.
Yes, you are.
Agenda. Yeah, I did just want to underscore the point that, and I know one of our upcoming agendas deals with this issue, but wanted to underscore the point that Tammy Venegay from DDS made, that to the extent that Medicaid is a driver of innovation and service delivery in our system, I think we always need to, and this is really a comment, not a question, but I think need to be very mindful that with every level of care that's created, or that we're paying attention to, that there has to be access for kids with ASD and ID, and that is not the case today, right? At any level that we're talking about, and it's so if we recognize as a group that we have a dearth of services, and I think we do in our continuum of care, that dearth is worse for children with intellectual and developmental disabilities. And I think we have to be very strategic in our attention to that in each step of analysis that we do here. So I think February's agenda is going to be looking at, I think, one of the upcoming agendas is coming up. Sorry, I thought that's coming up sometime in the next couple of months. People have said we're going to be looking at that. But I think it needs to be part of every discussion that we have. So that's just the point I wanted to make. I thought it was an important one, so I just want to underscore it. Thanks.
Thank you. And I'd like to turn it back over to Erica to give us what's coming.
Yeah, thank you so much. Just want to bring to your attention a couple of things. The meetings for January and February were revised due to accommodate, a couple of things and start of the legislative session. So we will be meeting January 10th. That particular meeting on the tentative agenda, because things do change, tentative agenda, we will invite Caroline and Anthem to continue on this conversation, as well as we had made a commitment to giving the space for in-home therapeutic services like ICAPS, MST, MDFT, all the ones that you have seen today. And then February, yes, Sarah, you are correct. We have already started doing an outreach to have a presentation on special populations. And so we will be engaged in that. The other thing I want to bring to your attention is that we have progressed pretty well in the level setting training that we have been asked to do. It's a 1-day level setting training. We have several partners here at the table. Howard, thank you. And Alice and several others who are assisting us with that. And in fact, we're meeting tomorrow to continue the development of that. But the date for that level setting training will be, as of right now, January 5th. We are holding that date, January 5th, unless there's a significant snowstorm. We are hoping to do this on January 5th. Registration for that training and further details will be coming to you forthcoming. Please know that this is very much more like a little bit more of an intro that will be diving a little bit further into some details, but I guess I want to be very mindful about who should attend. And so when we make the announcement on the training, we will be clear as to who should attend, because I wouldn't want people who, do this day to day to be sitting there all day feeling like, oh, I kind of knew this already, So we'll be very, very mindful of putting a description out about who is most appropriate to. But that is January 5th. It is an all-day training, and we will be sending out information on the registration. Thank you.
Okay, thank you very much. Unless there are any other questions, I wish you all a very happy holiday. Thank you, Bill and Fatmata. Very much appreciate the time and being in the hot seat as we weren't able to ask the questions of Caroline and Anthem. So thank you for that. And we will see you in January. Thank you.